Good evening, Dr. Snehal.
Good evening, sir. We missed you for last few sessions.
Yeah, I was conducting this thing, IVCF, and we were caught up in Tirupati, the darshan in the hall. We could, yeah, we went to Tirupati. We had a 7-day course, IVCF course. So,
Okay.
hello, Dr. Anjali. Good evening.
Hello, sir. Hello, Mohit. Sir, good evening,
Yeah.
Mohit, sir.
Hello, Dr. Mohite, sir. Good evening. Good evening, sir. So we went to see darshan on Friday, 4:30.
Hello,
We went to the.
Balasubramaniam, sir. Good evening.
Hello, good evening, Balasubramaniam, sir.
Good evening, sir.
You are not audible, Dr. Bala.
Good evening, Professor Srinivasan, sir, and Dr. Mahesh. Nice to see you. Yeah.
Nice to see
Snehal,
you, sir.
latest PCNA.
I
has,
tried my best, but last two Fridays back to back, there was Martyr IAP programs.
So,
I had to attend them. And the exactly same time, 9 o'clock Friday.
Yeah,
No
you
problem.
are,
Yes, sir. I wanted to attend one meeting, but it always coincides with genetic meetings.
yeah.
Yeah, this IAP meeting. Mohit, sir.
Dr. Snehal, that latest PCNA has all genetics. You will be interested.
Sir, today what I discussed with sir that last time there was a case of nephrotic syndrome and sir was asking genetic aspects, and because we are taking very primary pediatric student discussion, I thought that I should not take much time. But today I have made the next two slides after that, sir. So I'll just there is 1 minute to go. So as students join, I'll just display two slides in 2-3 minutes, sir. I will not elaborate on the genetic aspects, but I'll just show the two slides and the reference so that you can see it later.
Snehal, you take more than 5-10 minutes.
No, sir. Sir, because this is pediatric resident topic, and so today I have to have some more discussion after some time. So I will leave after some time, but I will take initial 3-4 minutes to go through.
No. 3-4 minutes not allowed. 10 to 15 minutes. Under that condition only, we are giving you a slot. 10 to 15 minutes.
No, sir. That is your generosity.
Now everything is genetics.
No, so what has started happening is last nephrotic, then Guillain-Barré, then thalassemia we discussed, and students are getting theory questions even about gene therapy, etc. Also, like all these SMA therapy. So I just thought I will keep summarizing in just one slide, not more than that.
You take 10 minutes minimum. Thank you.
Madam, see this book. One of my postgraduate, former undergraduate, postgraduate has written.
Yes, sir. This is a very nice book.
Yeah. She is in Hyderabad.
So today we have Pooja and Raghav from DY Patil. Hi, Pooja. Have you joined Pooja and Raghav? Pooja and Raghav from DY Patil. Have you joined?
They could have shown that jaundice child, Sudhakar, the photograph or a video, whether the child is active, not sick looking.
Yeah. That's okay. It's okay. Snehal, can we start?
Sir, I think Pooja and Raghav, have you joined? Are you able to join the discussion? Pooja and Raghav?
Sir, can we start initially with Dr. Snehal with her?
So I'll just show two slides till the students join.
You can show in the beginning as you are waiting. Good. Yeah. That's a good suggestion.
So this is nephrotic syndrome, which I had shown first slide. Sir, can you see now?
Yes, we can see.
Yeah.
You can make it full, full screen.
this slide I had shown in the last discussion about how to search for genetic causes. Then I have added 2 more slides, sir. This is one slide where there are International Pediatric Nephrology Association reference approach to steroid-resistant nephrotic syndrome, and they have written immediately after first approach 4 to 6 weeks to search for genetic causes. So I'm just quoting this reference so that you can just go, and this is approach to the resistant nephrotic syndrome. And sir, in their approach, they have in initial workup only, they have now ticked genetics. So if you can see, I have taken half of the table. Say the reference is very elaborate and very nice. Recent reference 2020. And in the initial workup only of steroid-resistant nephrotic syndrome, they have added genetics. And before transplantation, if it is not done, you have to do it. So in the same reference, I will just share the table which they have shown, which you were asking for.
What happened? Snehal got disconnected.
No,
She's
sir, I'm
there.
showing the table. I'm showing.
Yeah, she has shown the table. It is for us to go and see.
Sir, I'm showing the table of genes, just showing I'm not going to elaborate and explain, sir, but so that you can see that reference letter. I'm just sharing the screen again. So could you see that IPNA reference? Could you see that IPNA reference of approach to steroid-resistant nephrotic syndrome? No?
Your screen is not visible now.
Okay. So this is what I showed, no?
Yeah, now
Yeah.
it's visible screen. Yeah.
So this is what I showed, that initial only in steroid-resistant nephrotic syndrome, they've added genetics. This is what I wanted to show when this is approach in the same paper. And now I will show the list of genes which they have shown. I'll again share, sir. So this is another recent paper where they have listed 53 genes associated with steroid-resistant nephrotic syndrome and the diseases associated with it. So if you see this disease and phenotype, this gene has to be searched for. So this is a list, sir, you were asking for, right? Which includes genes and the syndromes associated with nephrotic syndrome. This was the list you were asking for, no, sir?
Yeah.
So if you get, and then if you get specific precise diagnosis, then this is another paper, sir. But if these genes are there, then the IPNA reference gives you the precise management references, how to precisely manage for these genes. So this is just from my side. I will send you these references, sir, on email.
Okay. Snehal, just one peculiar question. As a clinician, is there any genetic marker which can reliably predict steroid responsiveness right on day one?
No, sir, not day one. Actually, sir, this paper, I mean, this is steroid resistant up 0 also, sir. I'll show you the slide again, maybe. What they have done is.
Snehal, 1 minute. The Pooja is calling me that she can't join. They have not seen us.
Okay. So this is 0 months they have written. So maybe this paper will elaborate. We'll talk about it, sir, later. Maybe let students present. So this paper I'll send, and then we can discuss, sir. They're discussed in the paper. Okay. Pooja, if you can, Pooja and Raghav.
No, madam, they can't join. Snehal, they are unable to join.
They have joined, madam, but because I'm sharing screen, maybe they were not able to share screen.
Okay.
Yeah,
Because it's called. Yeah.
Pooja and Raghav, can you share now? I have made it off.
Yes, ma'am.
Yes, ma'am. Sir, I may have to leave a little early for another discussion. But
No problem. Thank you, Snehal. Thank you. Yeah, please go ahead, Dr. Pooja and Dr. Raghav Gandhi. We have the Professor Srinivasan in the lead with Dr. Mahesh also joining, and of course Dr. Anjali is there, very much there. Okay, over to Dr. Pooja and Raghav. Please go ahead.
Good evening.
Good evening, everyone.
So I am Dr. Pooja Vora.
I am Dr. Raghav Gandhi from DY Patil Hospital. We are pediatrics JR1 right now, and we are going to present a case today. So
This is the informant is the mother. This is a 7-year-old female child, 7.5-year-old female child. Gauri Pote, she was born out of non-consanguineous marriage, Hindu by religion, residing at Ulve, hailing from Pune, and was brought to casualty of DY Patil Hospital in active convulsion, which was preceded by one episode of vomiting. HPI, history of presenting illness. Patient was apparently all right till she developed one episode of vomiting, which was sudden in onset, non-projectile, not blood-stained, containing food particles, no aggravating or relieving factors. After which she had started convulsing and was brought to our hospital. On arrival to our hospital, she had 3 episodes of convulsions. Which were GTCF type, tonic-clonic movements of all 4 limbs, uprolling of eyes without regaining consciousness in between, and was lasting for 30 minutes. There was no deviation of angle of mouth, frothing from mouth, no bladder or bowel incontinence, and no deviation, and it was not aborted on injection medas. So hence, loading dose of injection phosphanatoin was given by 30 mg per kg. Patient's saturation had dropped to 76% on room air, and hence was put on 10 liters of oxygen support and was shifted to PICU for further management.
so negative history was taken. So there was no history of any fever.
One minute.
Yes.
So always you have just mentioned the story, and in fact, time and again we have been repeatedly telling in the sessions. Don't immediately go to negative history. Trace the entire symptom till today. This happened when the child's arrival at the casualty.
At 3 p.m., sir.
3 p.m. How many days back?
This was 15 days back.
15 days back. In the last 15 days, what has happened? See, the child arrived like this. See, in the presentation in general, whether it is exam or real life, what happened to this seizure? What has happened in the last 15 days before you talk about the negative history? Always, any symptom, make it a habit to take the presenting complaint in detail and trace it right up to the time you are discussing.
The patient presented in the afternoon at 3 p.m. there was an episode of vomiting just 5 minutes back to it, and then patient came with convulsion to our casualty. After vomiting, sudden convulsion was there.
Dr. Bala, can I suggest something?
Yeah, please, sir.
No, let us say these people are there in the casualty and this child comes. Okay, you are telling 14 days, no? Let us see if the child has come like this and they are in the casualty receiving that child and seeing that child. So what is their thought process? With the particular history I've just mentioned, the first 2 slides. So you are attending to this child as the child comes. So what will be your immediate process thinking? Naturally, the child is having a longer duration, already status of epilepticus. So what do you think is the probable cause? Then, of course, if you don't mind, Dr. Bala, we'll see, because emergency management, I'm trying to find out how they'll go about.
Fine, sir. Fine with me.
First of all, we will be, sir, securing airway, breathing, and circulation. So we will first be, we will see that patient's airway is not compromised. Second, we will do left lateral position and give oxygen supply. And then we will take a short history of NGT insertion we will do, so that aspiration would not happen, and oxygen supply we will do. Then suddenly, as patient has come in active seizure, so we will have midazolam nasal spray at right present, and we will spray.
Of course, it has been mentioned. The initial management with 2 anticonvulsants have been mentioned. Okay, so what will be this thing? Thought process. You have mentioned a few symptoms. with vomiting starting and then subsequently child is having sudden onset of generalized persistent convulsions. What
Yes.
would be your thought process from the etiological
So first
point
of
of
all,
view?
first I will think about there would be raised ICT, which leads to any abnormality might be there in the brain, which led to vomiting and then followed by seizure happened.
Or sir, any electrolyte imbalance can also cause this, sir. Hyponatremia, such as, or hypoglycemia.
Now, see, two things. You did not mention what was the time interval between the vomiting and the seizure. To me, that's very, very important. For example, I don't think I will think of electrolyte disturbance in a baby, in a child like this, who has been previously absolutely well. You had used the term apparently well. Coming with just vomiting, next few minutes seizure. I don't think I will think of any of the disorders you are mentioning, including raised ICT. In fact, to me, the most common, what do you think is the most common disorder which can present like this?
In this age group. And
Previously,
Dr.
normal-
Mahesh also wants to make some point.
Yeah,
Dr.
please,
Mahesh.
Mohit, you are most welcome. After this question, let him join, and Anjali also can join.
Encephalitis.
So
What is the most, I'm asking, I always believe that every pediatrician is a statistician, every clinician. When he sees any patient, mentally he puts an odds ratio. So what are the odds ratio of you being right if you make the following diagnosis, which is the most common diagnosis in the child
Could
like
it be
this?
encephalitis or meningitis, sir?
But meningitis, do you think meningitis will present with vomiting and seizure?
Yeah,
without
straight
fever?
without fever, without this thing.
I'm saying without fever, previously well child. So suppose the same thing had happened in a school.
So fever might have gone unnoticed. That is what.
That doesn't happen, man.
No.
That doesn't
Usually
happen.
the mother will be definitely saying that child is saying fever, then vomiting, and then this thing. But here definitely vomiting has started before this thing.
Yes, sir.
And naturally we had to think of increased intracranial tension as an important possibility.
Epilepsy presenting with status epilepticus. That would be the most common diagnosis in a setting like this. Previously well child suddenly starts vomiting and then develops a seizure, GTC seizure, status epilepticus, unprovoked seizure resulting in status epilepticus. That would be my first diagnosis. That is
Dr.
one.
Mahesh, your comments, please.
Okay.
I'll ask one more question, then hand over to Mahesh.
Yeah, sure.
Now, what type of seizure is this?
Sir, it is a GTCS type, so general tonic-clonic seizure.
Is that
So-
the way? Is that the way? What is the current classification of seizures which you are expected to follow? Correct terminology in seizure. What are the correct 3 groups of seizures as per International League Against Epilepsy? That's my fundamental question.
Sir,
How are seizures classified nowadays? Previously, in Dr. Srinivasan's time, in my time, it used to be grand mal, petit mal.
so it's divided into 2, sir, general or focal seizure. In general, sir, there are different types.
2 or 3. I'm giving you a clue. See, you must remember from 2017 onwards, the International League Against Epilepsy has modified the classification of seizures. And it is very easy to remember also. There are only 3 types. One is focal, the other is generalized, the third is idiopathic unknown onset, UKO. And what group does this? Generalized.
So generalized,
What in the generalized, what subclassification?
sir, there are tonic-clonic. One is tonic-clonic classification.
No. You must remember, both in focal as well as in generalized, there are further classification. In generalized, it is either motor or non-motor. Is this motor or non-motor?
Motor.
Motor, sir, motor.
Generalized motor seizure. Similarly, in focal, you have absence and you have awareness and impaired awareness.
Yes.
Yes.
Okay. So you must remember this classification. So to make it easy for the postgraduates, I'll say 3 groups. Okay, generalized, focal, unknown onset. In generalized, motor or non-motor. In focal, awareness present, altered awareness. That's it, the simplest classification. Similarly, in unknown onset, you have motor and non-motor, and the last group in unknown onset is unclassified disorders, unclassified, sleep terrors, etc., etc., etc. So this is a generalized motor seizure presenting with a status epilepticus, apparently unprovoked, because this is not fear provoked, this is not injury provoked, post-traumatic. Okay, and if you ask me, the commonest etiology is idiopathic epilepsy.
Yes.
That is the commonest cause. Okay, I wouldn't think of course, rarely encephalitis can present like this, but there will be some prodrome. And in a 12-year-old child, unlike infancy, the fever doesn't get missed. And usually in meningitis or encephalitis, fever is high. It's not a mild symptom. Hypoglycemia, hyponatremia, and all, it's insidious. It doesn't present acutely. There will be some background illness to make you suspect all that. Over to Mahesh.
I think you covered most of it. I just wanted to say what classification Bala sir said just now is called as a semiology based classification. So how the seizure starts. So classification are semiology based, classifications are etiology based. So it could be acute symptomatic, remote symptomatic, and idiopathic. That's the etiology based classification. And what Bala said just now is a semiology classification, which is a bit changed off late. I think it's only the terminology has changed. The basic understanding has not changed. So when he said about the focal seizure, it's previously used to be called as simple partial and complex partial. So one which is without loss of sensorium, it used to be simple partial. With a loss sensorium, it used to be called as partial seizure. Basically, we need to understand when they lose the sensorium, when the seizure is arising from both the lobes, both kind of hemispheres. So as long as it is restricted to one hemisphere, child usually won't lose a sensorium. One that kind of in olden time we used to call a Jacksonian march of the seizure. To start from one focal and then march to the other side and then gradually like. So equally important is to, from the history, what you saw is a generalized seizure, but ask the parents how it started. So quite often the mother will say that he had only flickering of right hand, then went on to develop right leg, then one full side, and then became generalized. So that will lead you towards a probable etiology. So what is very important is how was a child prior to the whole event? Like he started vomiting, but how was the sensorium prior to vomiting? So it could be variable things. Some child may have been lethargic since morning, and then in the afternoon started becoming vomiting, and evening started seizuring. That's one history, which is suggestive of progressive encephalopathy. Or it could be another one when the child was bang normal, sitting watching a movie, and suddenly vomited and went on to develop a seizure. And it could be another third one. The child was playing next to some puja place or somebody, and suddenly somebody found him seizuring. So that history prior to the event is extremely important when you're talking. Rather than going into negative history, I think how was a child in preceding 4 to 6 hours is extremely important when you're coming to some kind of etiological conclusion. And then next is how the seizure started. Somebody who has watched it personally, take him into confidence and find out whether it started as a focal. Sometimes they come with aura. The child suddenly shouted and then started getting a seizure. So that can give you some kind of, again, a focusing point. So how the child was prior to the event, how it started, how it progressed, and then how he responded to your immediate management. All those things are very important when you're taking the case further. Over to you, sir.
Now
Go
you
ahead.
can proceed. Yeah.
Go ahead.
So, because you as a emergency pediatrician, you would be managing such a case. So here you have seen after 14 days, maybe. When did you see exactly this child?
15 days back.
Okay.
He
Okay.
saw
Sir,
right
proceed.
on, you saw right on arrival. Okay. See, that's what, see, the differential diagnosis could be anything in this child. Okay, but as you said, since if the child had gone, I mean, I don't know whether this happen in sleep. You said night.
No, so afternoon.
Afternoon, sir, 3 p.m.
Yeah, afternoon 3 p.m. Does that have any relevance? Seizure occurring in the morning, afternoon, evening, night. What's the significance? In what way that could give a clue to you?
The
Remember-
juvenile myoclonic seizures generally happen in the morning because of
What? No. I'll
The
tell you.
hypoglycemic seizures will be occurring early morning as there is fasting of night.
Excellent. See, you must remember, majority of idiopathic epilepsies have got a tendency to occur during sleep. And in fact, the most notable example of a benign disorder. Can you give an example of a disorder which occurs during sleep? It's got excellent prognosis. You don't even have to consider giving medicine. I'm giving you a clue, benign disorder.
So many clues he has given regarding that.
Benign Rolandic epilepsy that characteristically occurs in sleep. Okay. Even GTC seizure is notorious to occur in the early mornings. As you rightly said, hypoglycemic seizure. Sometimes late in the night it can occur because sleep deprivation is one of the provoking factors for any seizure, sleep deprivation. But nowadays we even do sleep deprived EEG to get a epileptic activity in the EEG, right?
Yes.
And in general, myoclonic seizures tend to occur during sleep. Unlike extrapyramidal movements, which don't occur during sleep. These are some of the differences, right? So you must find out at late afternoon. Yes, did it happen in the school or at home?
At home, sir. At home.
At home. Okay. And as Mahesh pointed out, anything from camphor poisoning to drug ingestion to trauma to everything. Anything is possible at this point of time. A detailed history, whether the child went to school and came back, all that, those few sentences might have added more value regarding the probable cause for this.
Okay,
And you could have mentioned, and if you could have mentioned immediately that there is no fever which is noticed.
Yeah, another
Right.
important point to be discussed in the first slide itself is sudden dropping of oxygen saturation at 76%. Patient saturation on room air had dropped to 76%. So what would be the thought process now? Because child had seizures and suddenly you find that because they have given this information, so you should try to correlate what could be the problem.
Aspiration can also happen. As vomiting is there, vomiting followed by seizure. Aspiration can happen. So saturation can drop due to that.
Prolonged seizure itself can lead to hypoxia.
Yes.
Even without aspiration.
Or sudden coning with respiratory, this thing, medullary coning can occur if there is intracranial tension, can cause sudden death.
Laryngospasm itself.
Laryngospasm.
Okay. Or even apnea can occur when the seizure is prolonged, particularly in younger children. Go ahead.
Yeah, next slide. Yeah.
Anjali, you have anything to comment?
No, sir, no. Right now.
Please go ahead.
So the seizure was not aborted on injection midas. So hence loading dose of injection fosphenytoin was given and patient was put on oxygen support and shifted to PICU. So symptomatology, there was the negative history. There was no history of fever, no history of any headache, photophobia or inability to flex the neck. No history of any drooping of eyelids, nystagmus, suggestive of nystagmus or facial asymmetry, drooling of saliva, or regurgitation of feeds. There is no history of limb weakness, difficulty in climbing stairs, no history of any bowel bladder.
Why limb weakness and difficulty in climbing stairs?
Strokes.
Stroke. I'm not sure whether it is relevant at all. Okay, go ahead. Fine. Stroke.
No history of any epilepsy in the family. No history of sleep disturbances.
And there's no history of any sweating, irritability, or excessive hunger. There's no history of any blurred vision or frequent urination. No history of any nausea or fatigue was there, sir.
No, but I'm wondering how you are taking this history, because the child has become so suddenly sick. How she would have narrated to their parents. Even the parents won't be knowing what has happened. So you have given so many negative history. But unless she is conscious and able to give this history, how the parents would know? Even they would be surprised. So you have written so many negative history. When did you get this history?
Why did you ask excessive hunger? I'm curious to know.
Sorry, sir.
Excessive hunger. What did you think of?
No, the parents
Starvation.
themselves had sudden, no?
The starvation, any starvation history,
No, ma, you have put no history of excessive hunger.
fasting history, sir.
No, ma, no history of excessive hunger you have put. What disease did you keep in mind? That's what I'm curious to know.
See, my only doubt is, parents themselves won't be knowing because it has been sudden. Okay, and then how they would have got this history and all. See, of course, you may be asking the mother whether any of these problems are there.
Sir,
Okay, but
What disease did you think of when you asked for excessive hunger? Which disease which causes excessive hunger can give rise to a convulsion? That is my question to you. Simple question.
Where is the pathology?
the hypoglycemia.
Hypoglycemia, no. The other way. Will a child with excess diabetes, yes, somebody has put in the chat box. Polyphagia, diabetes mellitus can present with ketoacidosis and convulsions also, and coma also. Rare. That's the only condition I'll think of if there is excessive hunger in a child who presents with seizure. Okay, right, go ahead. And of course, excessive child feeling very hungry would be a symptom suggesting possibility of hypoglycemia. Okay, fine.
So past history, she was a known case. Actually, she was diagnosed as with ASD, and she was diagnosed with a large ostium secundum ASD, non-obstructive with moderate pulmonary hypertension, for which ASD closure was done on 15th of July, 3 months back. And there is history of one episode of seizure at 6 years of age, 1 year back, which was at the height of fever spike of 102 temperature.
What do you make out of this past history? Can you connect the past history with the present status epilepticus?
So initially the child had a simple febrile seizure.
Simple febrile seizure. I object, Your Honor. Why am I objecting?
6 years, sir, age.
6 years, yes. By definition, simple febrile seizures, the age is restricted between 6 months to 5 years. It's more what you call, I would say, tradition, right? And 6 years, first episode, I would not blame febrile seizures as the etiological.
So can we label it as febrile plus seizure?
No, don't give any label. That's what I'm trying to tell you. Don't give any label. That's what you don't know. You don't give a label at all. You could have simply said at 6 years, there was one episode of what type of, again, focal or general?
That was a GTCS.
GTCS type.
Your generalized motor seizure, tonic-clonic, with fever. Rather than
a little more detail is important. How many hours it was there, whether they admitted the child at that time or managed at home. All these things are important to know how severe it is.
duration.
How relevant
So,
it is.
my question is, how is that history important? How is the history of ostium secundum with pulmonary hypertension being closed important in this child?
Sir, not related, sir. It is just a thing that we.
Why not? Suppose I am saying it is related, the ostium secundum and the seizure. Suppose I am saying no, it may be related.
So if there would be any vegetation present inside, if there would be a history of fever, prolonged fever for continuous.
Okay, it's not likely to be infective endocarditis because
Yes.
nothing, no fever. Any other possibility? Somebody has put in the chat box. See, you have a cardiac lesion, even if it is closed, there is a slender chance of a thromboembolic phenomena. Definitely. In fact, you will be surprised to read from literature.
Even foramen ovale can cause.
Absolutely. As a cardiac anomaly, that is an MCQ. The most common cardiac anomaly in children with stroke is patent foramen ovale. The cause and effect relationship is not known, but if you do echo in children with hemiplegia or stroke, the commonest anomaly you pick up is a patent foramen ovale. Right? So like that, you never know. You never know. This can act as a focus for thromboembolism. Of course, infective endocarditis. Yes, the other important point you must remember about infective endocarditis in ASD, that unless there is what you call a synthetic patch which is put for closure, a simple closure of a VSD, ASD, and PDA does not cause any risk of infective endocarditis beyond 6 months after surgery. So it is recommended that you need not give infective endocarditis prophylaxis if you close VSD, ASD, PDA without a graft, and you need not give the prophylaxis beyond 6 months for procedures, endoscopy, etc. It's a low risk affair as far as the risk for infective endocarditis is concerned.
But I'm wondering why suddenly, immediately after the acute episode, they were straight away gone. They haven't mentioned what happened the subsequent days in these 14 days, how the child was behaving, whether there was recurrence. Nothing was mentioned, I think.
Correct.
Am I correct?
Yeah. You should have.
What happened in the last 15 days? No, you said 14 days. You haven't mentioned about the first episode you mentioned and the child was admitted and what happened, what is the progression? Because straight away you have gone to so many fast history, etc.
Sir, we had this child 15 days back, sir, when she was admitted for 5 to 6 days with us. And then we discharged the child and we had called her on follow-up. So since then, the child did not get a repeat episode of convulsion.
So
Child was sent home.
Yes, sir, sorry.
Child was sent home, not admitted.
Sir, admitted, yes, sir. Shifted for PICU admission.
For how long? How many days? And what was
PICU,
it?
sir, 2 days in PICU and 3 to 4 days in ward, sir.
And then child was discharged.
Yes, sir.
Yes, sir.
And child was normal, talking well. All these
Yes,
facts
sir,
are
normal.
important.
We
You
had
have to mention this.
investigations of MRI and EEG done also, sir. Which we have.
all this should have been discussed before you talk about past history.
You understand what I'm saying? What
Okay.
exactly was the behavior of the child after the child was brought to the hospital and how soon the child recovered and how soon the child was sent home and what was the condition? That is important, isn't it? When you are talking about the possibilities.
Ad nauseam, Anjali and me have been repeating this in every session. Please don't talk about past history, don't talk about negative history without completing the progress of the primary symptom.
Yes, progress.
Yes.
We can brief.
So we can briefly tell, sir. Actually, we have attached the investigations later on the later slides.
No, the progress, not investigation.
Progress.
Okay.
Yeah,
How-
you must not briefly tell. You must tell in detail all the aspects, not briefly.
So the patient was admitted in PICU after giving a loading dose of phosphanatoin and casualty. And in the PICU, the patient was given maintenance dose of phosphanatoin. And after that, the patient did not have any episode of convulsion.
How
So
soon the
hence
child became normal in activity and in talking? whether you could take the history from the girl herself or
Yes,
this
sir.
thing.
By evening,
Yeah.
she was fine, sir. By 7 or 8 p.m.,
After
she was fine.
post-ictal confusion
Post-ictal-
state phaser, she was very normal talking, and she was active also, sir.
She was
Don't you think
active.
these are all important to be told before you think of other past history, etc.? Yeah.
Hence since she was active and vitally stable, and she did not have any episode of convulsion, so she has been
We have,
shifted
we
to
have
wards.
investigated some metabolic also workup, so which was
Normal.
found out to be normal. So
After shifting to the ward, we did her MRI, brain plain plus contrast, and EEG. Sir. So MRI brain was suggestive of a arachnoid cyst in the
Pooja.
right.
Pooja,
Yes, sir.
sorry to interrupt you.
Yes, sir.
We want the clinical history detail followed by examination, then if required investigation. Don't jump onto investigation. First of all, as a senior consultant, somebody may go directly to this, but when you are learning the subject, try to discuss the subject, get the diagnosis just on a proper history, followed by, if at all, clinical examination. So don't tell us the report straight away. We are not at all interested in knowing the reports. You discuss the case. As sir has been saying again and again, onset, duration, and progress. How the child presented, what happened clinically in the ward, what happened subsequently, and what is the present clinical status. Okay, that includes history and examination.
Absolutely.
We
How
don't
soon the
want the
child came back to
investigation.
normal? Yeah.
Believe me, if you go to investigation directly, you are very likely to make a diagnostic fallacies or some
Correct.
mistakes. Always take a good history and try to make a diagnosis on that itself, right? And that's what is the purpose of this PG clinic. So just tell us the clinical progress of the child and we go on, right? Please do that.
So
Go
on
ahead.
examination, we found her.
No. Wait. See again, please don't go to examination. And I'm also very upset you're talking about investigation. Doesn't matter. Right? We pardon you. Don't worry about it. Now, the child regained consciousness in 6 hours. Am I right?
Yes, sir.
When was it extubated?
yes, sir.
When was the child extubated? Was intubated, isn't it, in the emergency?
No,
No, sir, not
no
intimate.
Not intubated. Okay. Was sent to ward and walked home after about 2 days with anticonvulsant. That's the story, isn't it?
Yes, sir.
Now you gave this past history. Now you go back to the remaining parts of the history and complete before we go to the physical examination. What about antenatal, neonatal, development history, growth history?
So family history, sir. There was no similar complaints.
No, I don't want family history. Family history last.
So birth history was not significant, sir. Antenatally, the mother was ANC registered. The mother was it was a
Is there
hospital.
anything significant in the antenatal?
There was no significant birth history, sir.
Birth history, sir.
Normal full-term
normal delivery.
Okay. What is the birth weight?
So birth weight was 3.5 kgs, sir.
Excellent. Yeah. Go ahead.
No NICU stay, no hyperbilirubinemia episode, nothing was there, sir.
Okay. What about developmental history?
So developmental history was also normal, sir.
Again, Anjali is there to vouch for the same. What about the weight, height, and head size of the baby or the
Yes,
child?
sir.
No, not an examination of the history.
Sir, anthropometry, sir. Height, weight.
No. Please go back to the history. See, again, this is the 100th time I'm telling you. History consists of not only developmental history, but also growth history. Suppose the child has not been gaining weight, your diagnosis will be different. Child has not been gaining height, your diagnosis will be different. Child has had a large head, your diagnosis will be different. Small head, your diagnosis will be different. So you should mention about weight, height, head circumference, teeth from the history compared to siblings or others in the neighborhood.
And how soon the child became normal to carry on the routine activities in these subsequent days, isn't it?
Yes,
Whether
sir.
the child was, yeah.
And the other important point that I forgot to mention, when you have an ASD, you always, in pediatrics, one anomaly means more
Another
anomalies are
congenital associated.
the possibility of a congenital anomaly in the central nervous system opens up because of the presence of an ASD. That's another answer I would have expected from you, right? Similarly, I would have wanted you to mention the head size, the height, the weight gain of the child, and also the teeth if possible. Please don't say in the examination I'll present. From the history, you can get all the data.
Sir, height, weight, and head circumference of the child were normal, ranging between 70th, 50th
No,
to
not on
70th.
examination. From the history, you should mention parents have felt that everything has been normal. Okay, go ahead. Anything relevant in the dietary history?
So, dietary history, there was a calorie deficit of 360 kilocalories per day and 630, and a protein deficit of 10.5 grams per day. So summarizing.
Wait. In a child who presents with status epilepticus, you should also obtain micronutrient history intake,
Micronutrient history.
whether they are vegans. Okay.
Yeah, micronutrient history is very important here. Yeah.
Okay, sir. Okay.
Yeah. What are those micronutrients, Dr. Pooja?
Ma'am, vitamins and micronutrients like zinc, like other.
Okay.
Which micronutrients are important for central nervous system? Specifically, your answer should be specifically iron, B12 and thiamine.
Calcium.
Iron, B12 and thiamine.
Iron and B2. Yes.
Okay, fine, go ahead. Fine. Please go ahead.
So summarizing, 7.5-year-old female child, known case of ASD closure, came in status epilepticus, preceded by one episode of vomiting with no focal neurological deficit in a fully immunized and developmentally normal child, suggestive of febrile seizure plus or epilepsy.
Then there is no fever at all in this episode.
So, at that point, sir, we thought if the fever might have gone undiagnosed.
You would have definitely recorded the temperature during the hospital stay. If there is no fever, why talk about the possibility of febrile seizure plus?
Not only that, 7.5 years old child. Yeah.
Epilepsy. What is epilepsy? What do you mean by the term epilepsy?
So basically, seizure.
What do you mean by the term epilepsy?
Any two unprovoked seizures in a day apart beyond neutral period is termed as epilepsy, sir.
Okay, in fact, it's a very vague term. It's a very vague term. It tells you that there is a disposition towards the recurrent unprovoked seizure. That's all. A disposition towards the recurrent unprovoked seizures has been defined as epilepsy in the so-called ILAE classification. A disposition. Okay. So, yes, but underlying causes have to be ruled out in this child, right? You must remember that idiopathic epilepsy is a diagnosis of exclusion. Exclusion. Okay, right. Go ahead.
So So, general physical examination.
Dr. Anjali, you want to ask some more questions?
Yeah. So you can easily say that epilepsy is an recurrent abnormal paroxysmal electrical activity of the brain, which is unprovoked.
Yeah.
So that's the way I remember. It's like I had made a mnemonic. I am very fond of like RAP, RAP. That is recurrent abnormal paroxysmal electrical activities of the brain, which are unprovoked. So they can remember in that way, sir.
Okay.
Dr. Baldev has put very nice questions. One question he has asked, what do you mean by additional vaccines? That's a very good question. What do you mean by additional vaccines?
So, like in this we give pneumonia.
Okay. The answer is very simple. There is no term called additional vaccines, right? In fact, history suggests that we used to use a term called optional vaccines.
Optional.
Optional vaccines. Okay.
That term itself was removed by the ACVAP about 7-8 years back. Beyond the UAP schedule, the vaccines advocated by ACVAP and other agencies, we used to call them as optional vaccines. That term has been removed now. On a similar note, there is no term which has any specific meaning called additional vaccines. Dr. Baldev, thanks, sir, for pointing out there is no term called additional vaccines. That is one. Second comment he has made, febrile seizure and epilepsy are contradicting DDs. Absolutely. Febrile seizure is not epilepsy. Epilepsy is not febrile seizure. Right?
Yes, sir.
Yes, sir.
Okay. Please go ahead.
So, general physical examination. So, patient is conscious, cooperative, oriented in time, place, and person, with the vitals of temperature 98.5°F taken at right axilla, with pulse rate of 80 beats per minute, regular with no radial or radiofemoral delay, with RR of 20 per minute, regular, abdominothoracic, with a blood pressure of 102/60, which is 50th 90th percentile. Pulse pressure was well felt, sir. Saturation was this was after coming to PICU, sir. After 6 hours, saturation came to 98% to room air when we have removed the oxygen, and so there was no pallor, icterus, clubbing sign, also lymphadenopathy or edema present. There were no signs.
Essentially, a well-looking child on general examination. The head looked normal.
So yes, head circumference was 49 centimeter with an expected 50.
By appearance.
The looking was normal. By appearance, it was normal. What appropriate?
Go ahead.
Yes, sir. I would like to tell them that here in the general examination only, they should say what is the posture. They said the behavior, that is conscious, cooperative. Okay. What is the growth and how does the child look, well nourished or not? And the head circumference. So everything will be covered in that one line in your general examination when you start.
Okay.
Very rightly said, Dr. Anjali. Yeah.
Anthropometrically, there was with the expected height of 120 centimeter was there, 20 to 50th percentile. Weight was 50th to 70th percentile, and head circumference was 2% to 50th percent, according to WHO. There was no stunting or wasting present, sir. BMI was 17.
What did you plot the weight, height, and the?
Yes, sir.
There is a chart. There is a growth chart.
We didn't have.
You should any presentation, leave alone examination.
Let us the chart.
Exams or no exams, you should plot the weight and height, make it a habit. In fact, you should not stop with only the weight and height of the child, also the mid-parental height of the child.
Yes.
You should plot it. Without growth chart, Dr. Baldev has very clearly put growth chart. Yes. See, senior person. He's not saying it without a good reason. But that can give a diagnosis, right?
Yes, sir.
Go ahead. But it
So
was normal from what you say. Even what is the BMI?
17. 17.
Okay, fine. Right.
So head to toe examination, head was normal. Eyes, there was pallor in the lower palpebral conjunctiva that we could see. Mild pallor, sir. Nose was normal. There was no DNS or anything. Throat, tonsillar enlargement grade 2 was present. Ears
How
were
do
normal.
you grade? How do you grade tonsillar enlargement? How do you grade tonsillar enlargement?
So there are 4 stages, 4 gradings. One which is within the tonsillar fossa. So 2 which is within the tonsillar on the enlarging, which is crossing the tonsillar fossa. The third one, which is between which is like 50 to 70% occupying the tonsillar cavity, and fourth one is they touch each other. That is
Kissing tonsil is grade 4.
kissing tonsils.
Yes.
Kissing tonsils are grade 4, sir.
Treatment gradings are classification.
3 is close to the uvula. 2 is outside the tonsillar fossa. Grade 1 is in the tonsillar.
Less than 25% occupying, sir, grade 1, and 25 to 50.
50% is
What is the relationship between the tonsillar size and the age of the child? What is the relationship between the tonsillar enlargement and the age of the child? Okay, now before that, do you know the various patterns of growth of different organ systems in the body? And do you know the way the lymphoid growth takes place in children? When does it reach the peak? The lymphoid tissue growth.
Lymphoid tissue.
4 to 7 years. 4 to 7 years. Remember, the lymphoid tissue growth reaches its peak between 4 to 7 years of age. That is very important. That is the age in which unnecessary tonsillectomies are done. Irrational diagnosis of chronic or recurrent tonsillitis is made. That is because the lymphoid tissue growth is at its peak between 4 to 7 years. After 10 years, it starts subsiding. It's a very important point. So 12-year-old grade 2 is very much within normal limits.
normal limits.
Okay, go ahead.
So ears were normal looking, sir. There was on the skin, there was a surgical scar present on the chest of ASD closure.
What? See, it is not enough if you simply mention surgical scar.
Yes, sir. It was 7. We had measured
What,
it. Sir.
was it a vertical scar or a horizontal scar, one scar, two
Yes, sir.
scars there?
Sir, it was a vertical scar, sir, of 7 into 3 centimeters, and
Where?
it was present on the chest, sir.
Just which
On the midline.
portion?
In the midline, sir.
Sternum. You say
Sternum.
sternum. Yeah, because sternotomy is the commonest procedure utilized to open the heart and perform intracardiac surgery. Right?
Yes,
In
sir.
fact, in the MRC-PCH exam, they used to give a lot of importance to the different types of scar. Right? To identify what procedure they would have done in the past. Right. The presence of a sternotomy scar indicate that an open heart procedure has probably been done.
Yes.
Because even in PDA, you may open the sternum sometimes to close the ductus, right? Right.
So abdomen was normal looking, and the spine was normal. Hair and nails are also normal. So dentition, there were six teeth present in each quadrant, and there were no dental caries. Sir.
How many teeth are there?
24.
26. Sir. You put 6 is total, it's coming only to 24. You are saying 26?
24.
24. Thank you.
The CNS examination,
What
normal.
is the order of 1 minute? Go back. Let us not forget dentistry. What is the order of eruption of deciduous teeth? What is the order of eruption of permanent teeth? And how many teeth normally you expect in a 12-year-old? Don't tell me this is not dentistry. This is pediatrics only. Anybody can put in the chat box? What is the order of eruption of teeth, deciduous teeth? See, you must remember, very simple. By 6 to 8 months, the first deciduous teeth appear, right? That is it. Which is the first teeth to appear?
Yes.
See, first teeth to appear, deciduous teeth, central incisor, yes, lower incisor, okay, and 212, there is no premolar, okay, incisor, canine and molar, 212, and they are around 1 year of age, you get about 6 to 8 teeth, and by 2 to 2.5 years, you get about 16 to 20 teeth, and they start falling from the age of 7 years. But if you go to second standard in any school, many children will have loss of teeth. Okay, 7 years. And they start falling at the rate of 4 to 6, and the permanent teeth from 8 to 9 start appearing at the rate of 4 to 6. And wisdom tooth appears last. That's the way you should remember. 12-year-old, 24 is very much normal. Go ahead.
CNS examination, the higher mental functions like speech, memory, and language were intact and normal. Cranial nerve examination, while testing the first.
Wait. What are the normal higher mental functions? What are the normal higher mental functions?
Speech, memory, language.
That's all. Only 3. Yeah?
So consciousness.
Anything else? Somebody has put sleep. Okay. Easy to remember, man. Appearance, behavior, consciousness, delusions or hallucinations, memory, intelligence, emotion. E is emotion. I used to remember as A, B, C, D, E, M, S. Memory and speech, and also intelligence and behavior. That is higher function. So to remember higher function, remember A, B, C, D, E. Appearance, behavior, consciousness, level of consciousness, stupor, coma, delirium, etc. Then D is delusions and hallucinations, psychiatric manifestations. E is emotions, okay, and memory, orientation in time, space, and person, speech, intelligence. All these are higher functions. Not simply speech, memory, and language. Okay? Particularly in a child who has had a status epilepticus, behavior should be assessed, delusions and hallucinations should be inquired into. Simple test for reason and past memory in a 12-year-old child can easily be carried out. Go ahead.
Sir, does the gate come in this higher function?
No, gate comes only in.
No higher function. There's motor
Okay.
function. Yes.
Okay.
Comes only after the tone, power, along with cerebellar systems.
Okay.
So cranial nerve examination. First nerve, the sense of smell was intact, sir. Second nerve, field of vision was present. Color vision was also present. Third, fourth, and sixth nerve,
What
extraocular.
is abnormal in the?
Yeah. If it is normal, you can mention all cranial nerves are normal.
Cranial nerve examination was normal, sir.
Yeah, it's enough if you say that. Yeah.
Sir, motor examination, the posture and the gait of the child was also normal. On nutrition, the upper limb on the left side and was 20 centimeters, right side was 20, lower limb was 30 centimeters, and the right side was also approximately 30 centimeters. So it was bilaterally equal, sir.
Wait. I don't. You must say 30, 31 centimeters. Which part of the limb?
Which part of the sir, upper limb on the On the biceps muscle, sir.
Mention, you should mention which area. Okay, fine. But you need not mention and measure this unless there is some suggestion of wasting or atrophy, right? There's no need to routinely do it, particularly in a child who's got a normal gait and posture, right? Fine.
So there was no wasting, sir. The tone was normal. Power of all the limbs were 5/5. Reflexes were 2+ and normal. Both superficial and deep reflexes were intact.
What about plantar response and abdominal reflex?
So flexor plantar response.
Okay. Sensory normal.
Normal. Sensory.
Normal. Okay.
Yes. So sensory examination. Touch, pain, temperature normal. Tactile sensations normal.
Everything normal. Go to the next slide. Go to the next slide.
Yes.
Okay. Now, anything else you missed out? Tell me. Something very important in nervous system you omitted. Can anybody put in the chat box?
Even skin is important because the epidermal structure, both this thing, you have to say no neurokidney markers.
Spine and cranium. You can't afford to miss a spina bifida. Okay. You can't afford to miss, as sir said, tuft of hair, lymphoma, hemangioma in the back.
So with general examination, spine was normal, sir. Examined them.
You should
No,
mention.
whenever you talk about neurological system, talk about the skin because there are so many neurokidney syndromes can present at any time.
Yes.
So you may say nothing, no neurokidney.
Absolutely. That's what
Because you have mentioned.
very correctly putting in the chat box. Skull, spine, and gait. You should mention the skull and that is spine and cranium routinely in every nervous system examination. More so in a child who is presented to you with status epilepticus. You cannot miss an Arnold. You can make out an Arnold cherry. You can make out spinal abnormalities. You can make out even clue to Andy Walker malformation, right? How do you get clues to Arnold Chiari and Dandy Walker? By inspection. Arnold Chiari and Dandy Walker. See, remember,
Arnold theory would be a present at birth only, sir.
no, if there is spinal dystrophism, there may be associated Arnold Chiari malformation. Okay. And Anjali has put occipital enlargement. What does it mean? Enlargement of the occipital region. Enlargement of the occipital region. A cystic enlargement of the base of the brain. Which condition you get cystic enlargement? You get cystic enlargement of the base of the Dandy Walker. Okay, go ahead. Go ahead. Go to the other systems.
Yes. CVS examination, sir.
Okay.
So inspection, precordial bulge was present, sir. Bilateral symmetrical chest moves equally with respiration. Apical impulse was seen at 50 intercostal space in the mid-clavicular line. There was no epigastric pulsation seen, no suprasternal pulsation, no so there was a scar seen. Sorry for the mistake. There was scar seen in the center, though there was no veins or sinuses seen, sir. On palpation, superficial palpation, inspectory findings were same. Apex beat was felt at 50 intercostal space and the mid-clavicular line in the center. Palpable thrill was present and personnel heave was present. Percussion, sir, left border, which corresponds to the.
Did you find anything in the cardiovascular system?
No, sir. Auscultation also sounds were normal, sir.
Okay.
So as all it was closed.
ASD, there will be no thrill, but you said thrill is present,
You didn't find anything abnormal in the cardiovascular system. Leave it. Next. Respiratory, normal. Abdomen, normal. Am I right?
Yes,
Yes,
sir.
sir.
Okay. Give a conclusive summary of this child. Anjali, you can start asking questions on the summary of diagnosis.
Okay. Yeah, Dr. Pooja, say what is the summary now? What do you
So,
think?
7.5-year-old female child, known case of ASD closure, came in status epilepticus preceded by one episode of vomiting with no focal neurological deficit in a fully immunized and developmentally normal child, suggestive of mostly unprovoked seizure.
Status of yes. Okay. So okay.
गर्म कर ले ये तो
So then
गर्म
what-
नहीं
hello.
वो गर्म नहीं हाथ लगे को ठंडी है
There is
ना
some
माइक
disturbance,
ऐसे कर जब देख लो मैं भी खानी थोड़ी सी गर्म करके ले आओ ना मैं भी
माइक्रो कीती है पहले
माइक्रो नहीं करनी ना ਉਹਦੇ ਚ ਕਰ ਲੋ ਯਾਰ
Hello, please.
ਗੰਦ ਜਾਂ ਪਲਾਸਟਿਕ
Please mute yourself.
I still wonder why trill is present, because they have mentioned trill is present in a ASD.
Sir, no thrill. She said no thrill.
Acha, no trill. Okay.
and sir, she has said fully immunized. I think Dr. Sir has said well. Prajapati sir has said he is not a fully immunized child. Dr. Pooja,
Fully immunized as per
during
as per the national immunization.
national immunization study only has taken. No optional vaccinations they haven't taken.
Again, don't use the term optional vaccination. Just now I told you,
Yes, sir.
Yeah.
immunized as per the national immunization schedule.
immunized as per national immunization schedule.
ಅಮ್ಮ ಯಮ್ಮ ಒಂದು ಲೈಟ್ ಅಂತ ಇರುವ
Hello.
ಅಂತ ಬೆಡ್ಶೀಟ್ ಮಟ್ಟ ತಗೊಂಡ್ಬಂದ್ರು
Anjali, take over. Again, Bhagavan
sir.
was asking cardium bulging. Why?
Why there is a bulging, Dr. Pooja, for that ASD? Hello.
Yes, pardon, ma'am.
Yeah, why there is a bulging? Dr. Prajapati is asking why there is a bulging.
There was no
They said no, there is no precordial bulge.
no precordial
Normal,
bulge,
ma'am.
normal bulge.
Okay, so there is no
They
precordial
put it as
bulge.
no precordial bulge. No precordial bulge. Okay.
So then what is the cause for that status epilepticus with ASD? It is?
Ma'am, that only we investigated further. As history, according to history, ma'am, there was unprovoked seizure only we could find out because there was no evidence on CNS examination or general examination or no history or past history.
Did you examine the fundus? You never mentioned.
No, sir, we didn't, sir.
Why? What is the importance of fundus examination? A child with unprovoked seizures and fundus examination. What are the clues you can get? Unprovoked seizure and fundus examination. How can you connect the two?
So we generally look for papilloedema.
One is papilledema. Is that the only one? You can have even a cherry red spot.
Child red spots.
You can have optic atrophy. You can have a bleed, particularly in a child with a cardiac disease. Okay, because it's not infected endocarditis. I'm just saying it can be a bleed. It can give a clue to the presence of the possibility of an intracerebral bleed. Okay, and a presence of papilledema in a child who has got an unprovoked seizure like this will always give you a clue. There may be a structural abnormality in the brain.
Brain.
There is intracranial tension,
No, no,
space
no.
occupying lesion. Okay, right. Other than fundus examination, in a child with unprovoked seizure, what are the other clues? Again, you did not mention in the clinical examination, general examination. One more important marker. I'm giving you a clue. Marker. Neurocutaneous markers
Cutaneous markers. There was
specifically look for in any child with an unprovoked seizure like this presenting a status epilepticus,
yes.
right? Okay. Neurocutaneous markers. That's why I gave a clue as marker.
Yes, sir. Neurocutaneous.
Okay. Right. Now, in this child, how do you suppose you are the resident and you have given phosphoenzyme, child comes out in 6 hours. What are the basic investigations you will do to proceed?
Sir, first of all, we will go for, sir, glucose checkup. HGT would be done, sir. HGT at the time of seizure would also be done to rule out hypoglycemia. Electrolytes we will do, sir. Calcium we will do. Hypocalcemic seizures as can be a cause.
Metabolic workup.
Metabolic workup basically, sir, we will do. First.
Basic workup for the first episode of seizure is, as you rightly said, electrolytes, including urea, creatinine,
Including calcium,
calcium and magnesium.
magnesium.
Calcium and magnesium.
Remember, hypomagnesemia can mimic hypocalcemic seizure, and it is not enough if you do only calcium. And the other important point you must remember, whenever you ask for calcium, you should ask for some other estimation. What is that?
Ionized calcium.
Ionized. Anything else? You should not interpret calcium. You should not interpret calcium level without interpreting something else.
Alkaline phosphatase, sir.
No, albumin. Albumin.
Albumin.
Any calcium, if you do, you should always ask for albumin. So calcium, magnesium, electrolytes, albumin are the basic minimum tests you should do in a child. In addition to glucose, you do an urea creatinine in a child with status epilepticus. In this child, what are the reports of this? What are the reports? Yeah.
So, yeah, sir, the CBC, metabolic workup, HGT, everything was within normal limits, sir. Electrolytes, everything were normal.
Okay, Dr. Pradapati is asking, why should you do albumin? Can you explain? He is asking you to explain. If you don't explain, I'll explain. If albumin is low, calcium will be deceptively low.
No.
That is why you always estimate albumin when you estimate calcium. Right.
So then we did a 2D echo as well, which was normal. And then we got a MRI brain plain plus contrast done.
When do you do MRI or neuroimaging in a child with first episode of unprovoked seizures? What are the indications?
So generally, if it is a focal seizure, we do go for a MRI brain plain plus contrast to see if there is any space occupying lesion in the brain.
Generally, you're giving a correct statement. In fact, you must remember in pediatrics, a focal seizure is not as sinister as in adult medicine. In adult medicine, any focal seizure, yes, we should rule out a local vascular or a structural lesion. Pediatrics, even metabolic disorders can cause focal seizures. For example, you have hypocalcemic seizure, they can be focal also. They need not be generalized because of the immaturity of the brain. And for example, in neonates, you can have focal seizures, focal clonic or focal tonic seizures without a local abnormality, focal abnormality. Okay. The moment you suspect a structural lesion, you should always do a neuroimaging, and the neuroimaging of choice is definitely MRI, considering the risk of radiation from a CT scan. Okay, go ahead. Yes, Anjali, you can proceed.
Go ahead. What's the MRI report then, Dr. Pooja?
Sir, ma'am, so MRI report was suggestive of there was a arachnoid cyst which was present in the right temporal fossa.
You have the pictures?
Yes, sir.
The area and size is very important.
Right temporal, so prominence of CSS space was noted.
You have the
Involving
pictures.
the
You have
medial
the,
aspect of the right temporal fossa.
Usually
have
it's
the
temporal.
pictures.
Yes.
you have the pictures. Do you have the pictures? Yeah. Can you show us where the lesions are?
So actually, we did discuss it with the radiologist. He said in the middle temporal fossa on the right side, he's seeing a small lesion, which he was also doubtful whether it is a calcified mass or a cyst. So he was like, it might be. He gave the report as query arachnoid cyst.
I don't know. I'm not a radiologist nor a
Of
neuro.
course, whenever a cyst is there, of course, the commonest is, of course, neurocystic sarcosis. We have seen so many in, Pratibha Segi has published so many, as well as we have seen also. Whenever a cyst is there, with unprovoked convulsion, we have to think of this thing. But anyhow, the temporal lobe is very characteristic. It's arachnoid cyst. It's commonly seen among some of the malformations. And they may present as ataxia or temporal lobe epilepsy.
Yes, sir. So after this, sir, we got a neurosurgery reference done in our hospital. They said that the seizure and the arachnoid cyst are not related, and there was no surgical intervention that was needed.
Usually they don't do anything. Yeah.
Yes, so they said it is just a common finding that is
Accidental finding that we have
is-
found.
Yeah.
Otherwise, it is not related, sir.
There are 2 or 3 important points a clinician must remember when he has an MRI report in his hand. The first important point, often forgotten by pediatricians, is that if you do an MRI after doing a lumbar puncture in a child, that is, many a time we do lumbar puncture for meningitis, suspicion of meningitis, and we rule out meningitis, then we ask for MRI. If you do an MRI in a child after a lumbar puncture, due to the release of pressure by the procedure, I believe the MRI may show contrast enhancement. And the radiologist might report increased contrast enhancement suggestive of meningoencephalitis. This is something which clinicians must remember. So it is preferable to do a lumbar puncture after an MRI than before MRI. 2, if the MRI reports say meningoencephalitis based on contrast enhancement, if you have done a lumbar puncture, that finding is not reliable. That is number 1. Number 2, any small cystic lesion, unilateral or bilateral, uncalcified, no edema surrounding, no midline displacement, don't blame that lesion for somebody who has a status epilepticus. This is an incidental finding, likely. 3rd, if you do CT scan immediately following a prolonged seizure, within 24 hours, if you do a CT, the CT may be reported as showing ring lesion.
Yes.
That is because of a edema occurring due to a prolonged seizure. Okay. For example, the lesion, the radiological lesion, which is characteristic of neurocystic sarcosis, by radiologists is called as single small contrast enhancing computerized tomographic lesion. the correct terminology, they don't use the term, radiologists don't use the term ring lesion. They use the term SSCETL, CTL, single small contrast enhancing computerized tomographic lesion. That is the correct radiological entity which occurs characteristically in neurocystic sarcosis. Last, for the pediatrician, is that a pediatrician should distinguish, if possible, a tuberculoma and a cystic sarcosis based on some fundamental point. For example, there are contrast, lipid, other things which the radiologists are conversant with. Let us not worry about it. For the pediatrician, the following findings will help us differentiate a tuberculoma from a neurocystic sarcosis. What are those findings? Can you tell me? Pediatrician's view. How do you distinguish neurocystic sarcosis causing a ring lesion and a tuberculoma which causes a ring lesion? Can you tell us some points? Very simple, I'll tell you. One, size. In general, the lesions in neurocystic sarcosis are less than 2 centimeters, whereas a tuberculoma is likely to be bigger than 2 centimeters. Two, perilesional edema. Perilesional edema is more characteristic.
ICD, sir, raised ICD. There are no signs of ICD in tuberculoma.
Third is midline shift.
Midline shift, yes.
More characteristic tuberculoma. Four, in general, your cystic sarcosis has got a tendency to be in the cortex, whereas tuberculoma lesions are more likely lower down in the brainstem. Last, scolex, if visible, it is very, very characteristic of
Neurocystic.
neurosis. Okay, these are all pediatric points. So they will say colon, lipid layers, etc., with contrast, which will tell you whether it is neurocystic sarcosis or tuberculoma. Okay.
Yes,
Sir,
sir.
I remember Professor Srinivasan will remember. Sir, Dr. Adi Sivan from Jipmer.
Yeah, Starry Sky.
Starry
Sorry,
Sky.
Archives of Disease of Childhood. It's the
Yes, sir.
both the children came from this thing.
ADC images.
Okay. Yeah.
EGs can go and put a search.
Yeah. Many times after that, we have seen many children with the Starry Sky appearance.
Yes. Okay. Right. Thank you.
That's
Go to Anjali and Mahesh.
more than.
Mahesh and Anjali.
No, I think you have covered everything. I was just patiently listening and noting down few points right from the history part itself. They mentioned there is no history of neck stiffness. Neck stiffness is never a history. It's a clinical finding. Okay. So
Yes.
you also mentioned that he was finding no history of finding difficulty in flexing neck. In 30 years of my practice, I have never seen a pyogenic meningitis coming with this history. With the frank. So that is never a history. Okay. So avoid those kind of terminologies.
Yes, sir.
Second, sir said about a febrile seizure 6 months to 5 years, but mind you, majority, I would say 99% would have their first seizure before 3 years. The subsequent may be on third or fourth or fifth year. The first seizure by and large would never happen after 3 years. So just to note that. Then you said closure of ASD for pulmonary hypertension. Once they develop pulmonary hypertension, is Eisenmenger, there is no role of any surgery following that. So probably they must have done it hyperkinetic pH, or maybe as usually we do it, or max around 5 years. That's the time they must have done with the early pulmonary hypertension. So we know more details about that. So third, the bacterial endocarditis is least common with ASD of all the left to right shunts, whether it is VSD, ductus versus ASD. ASD is the last one to have bacterial endocarditis simply because there is no pressure gradient at that level. So all post-tricuspid lesions like VSD and ductus can have a higher chance. For that matter, all even right to left shunt can have a higher chance of bacterial endocarditis. ASD per se has a very, very less chance because the pressure gradient between two atrial compartments is never more than 20. And unless and until you have that pressure gradient and hence the turbulence, you have lesser damage to the borders of the lesion. So lesser chances of vegetation and endocarditis. It's least common to have it. Yes, post patch. So for that matter, any cardiac repair surgery, there is always a higher chance of bacterial endocarditis. But as you said, it will happen within 1 to 2 months, a bit less likely. So that you need to be careful. Now about a general examination, perhaps all systemic cases that you get relevant to that systemic case, there are features in the general examination. For example, you are getting a congenital heart, then I'll be more in details about the pulse, the blood pressure, the pulse call, the feature, the volume, the regular, irregular, and central peripheral difference, and all those things, So I need to be, so similar in case of a neurological case like this, my general examination has to mention about neurokidney stigma and dysmorphism.
1 minute, Dr. Pooja, can you stop sharing the screen? So that Mahesh can go on. Please stop sharing the screen. Mahesh,
Yeah.
sorry for the interruption. 1 minute.
So
Please stop sharing the screen. And Mahesh, you please go ahead. Yeah.
So basically, you are mentioning about general examination. Apart from the, how I usually take my postgraduates is first to mention about the vitals. Then you go for anthropometry, interpret that, and then go to the findings relevant to that system, and then finally head to toe. So maintain that sequence that makes it more sensible. So for example, if you are having a respiratory case, then I will definitely mention whether there is any cyanotic tinge or clubbing or something. So cardiac case, I will be going more in details about this pulse, forelimb saturation, forelimb blood pressures, forelimb pulses, the pulse volume, and apex pulse deficit, all those things that we mentioned, or a JVP, that they are all part of the general examination, though relevant to cardiac system. So I need to take them upfront. In case of neurological system, here in general examination, neurocutaneous stigmata are extremely important. If there are any caffeolus spot, if there are any kind of ashy lip spots or ashy lip macules, so those kind of things, especially when you have a seizure disorder, they have to be mentioned in general examination. And then finally, to complete your dysmorphism, not to forget dysmorphism, you may be missing something in that. So they will be helping you. Arachnoid cyst you mentioned, that's one of the most benign condition in the brain. As sir said, that's it, just kind of a chance finding in majority of the times. Very rarely they may lead to raise ICP, that too a very subacute onset progressive. They're never an acute presentation, never. I mean, we must have seen quite a good number. They are never kind of a, I know walking, talking and graduate children by this time who never had any botheration of arachnoid. For some reason, they did a scan and they detected and never had any problem. One thing about the MRI post-status epilepticus, you can get the picture which is false presentation of a diffusion restriction. So you have a prolonged status epilepticus, you may get the areas of diffusion restriction. So it should be always correlated with the ADC mapping. Having a diffusion restriction with correlating ADC mapping, that is white on diffusion restriction and dark on ADC, that's an infarct. And if you have white on diffusion mapping, and without any ADC correlation, that is to be taken as a transient ischemia following a prolonged status epilepticus. You ideally should repeat that MRI after 48 hours and you might find all the lesions are totally gone. So before labeling it as infarct, we should be careful there. And I think about the TB versus NCC, one more feature I'll definitely add. If you have an MRI T2 weighted, if you have a white water inside the cyst, that's a NCC unless proved otherwise. If the center is dark, it's a tuberculoma, and rest all Balasar and Prajapati said already mentioned. In between, I suppose a lot of, but let me be very, very honest, Pooja and you. Next time you practice it before presenting. A very honest guess. I hope please don't misunderstand us, but you are presenting on a very privileged platform with three of the best teachers available in this country. Dr. Bala is there, Dr. Srinivasan sir is there, Dr. Baldev sir is there. Believe me, I was never lucky to have these kind of teachers to present my cases. I would have been a much better pediatrician had I learned from these guys. So you are really lucky to have an opportunity to present these people. So spend some extra time, present to your seniors, present to your registrars, present to your lecturers, get it polished so that you will get a much better outcome from this, because otherwise they have to, go on some basics where valuable time may be missed from your point. For them, I can just imagine the patients, Dr. Bala or Subramaniam sir, they execute in this clinic, because ultimate goal is to teach you. Ultimate goal is to transform the knowledge from a full of kind of a knowledge to who are just wanting to get knowledge. But while doing so, try to cover the basics so that you will have a much higher quality, I attended simply because these are the best teachers in the country today. You are really lucky to be kind of mentored by these people. So to make the best out of it, take this case at least 2-3 days prior, read about the case, present it to seniors, polish it further, and then come back. I'm sure you will be much more happy than all of us there. Thank you very much.
Thank you, sir.
Okay, sir, Professor Srinivas, is there any final comments? And Anjali, you have any-
Whenever a seizure is there, neurocutaneous markers have been repeatedly telling. Of course, Dr. Balde also telling, because at any age it can present. So look for it. Otherwise, of course, when you are presenting, tell about the immediate outcome of the child till the time of discharge. Okay, that is very important. Okay. Thank you. We have done well. So, of course, excellently discussed. Thank you, Dr. Makesh. It's always a pleasure to listen to you.
Anjali, your comments?
Yeah. Only in the CNS also, just to complete the list, the cerebellar signs and the meningeal signs. I think that they have not mentioned. So to complete the list of the CNS system.
They mentioned cerebellar signs.
Yeah, cerebellar signs I mentioned.
They mentioned,
Especially
okay.
subarachnoids is very important because occasionally they present if it is there on the
Yeah.
posterior fossa. Yeah.
On the spine and cranium, they missed out. That's all.
Yeah.
Okay. Thank you,
Thank you.
Pooja. And,
Thank you, everyone.
Thank you.
Thank you very much.
and your good name, please. Pooja and
Raghav, sir.
Raghav,
Raghav.
Pooja.
well done. As Mahesh suggested, there is only one thing we can all do is to improve our
Yes,
skills
sir.
and
Yes,
knowledge.
sir.
All
Yeah,
the best.
now that Mahesh has said so much, we are also trying to improve. Dr. Mahesh knows I am a very good student. Whenever they say I am teacher of teachers, I always say I am teacher, student of.
All the
Yeah.
clinics, the teacher learns maximally. I can
Yeah.
bet on that. We learn
You
more
ask
and
Dr.
more.
Prajapati house,
Yeah.
don't miss any PG
Absolutely.
discussion. Thank you.
Absolutely.
Thank you.
Thank you.
Because it's
Thank you.
always a
very much.
learning experience.
Yes.
And of course, Dr. Bala always says he must be the editor for Nelson, the Indian edition.
My
Yeah,
God.
he knows thoroughly about Nelson.
Thank you, sir.
Yeah. Thank you.
Thank you very much. Sir.
Thank you,
Thank you.
sir.
Thank you.
Thank you.
so much, sir.
Thank you, sir.
Yeah.
Thank you.